It's time for another warm-up. Let's get going. First question here, why should beta blockers never be used in cases of suspected cocaine intoxication? Well, beta blockers can actually lead to severe hypertension in patients who are using cocaine because of unopposed alpha-1 activation and blockade of that beta-2 vasodilation. Next, what is the embryologic origin of each of the following adult structures? So all these, the olfactory epithelium, the mammary glands, and the parotid glands, and the sweat glands, they all come from surface ectoderm. Next, what defects are seen in a patient with transposition of the great vessels? So you're going to get pulmonary trunk originates from the left ventricle, and the aorta originates from the right ventricle. All right, that's it for the warm-up. Let's get to that lecture.
In this video, we're going to discuss mycobacteria. So we're going to start with Mycobacterium tuberculosis. Now, we don't see a lot of TB in the U.S., but it's one of the most common causes of death worldwide, and about a third of the world's population has been infected with TB at one point in their lives. Mycobacteria are different than a lot of other bacteria. For one thing, they grow very slowly. They divide about once every 24 hours rather than once every 20 minutes like E. coli. So this means that growing mycobacteria in culture is a long-term commitment. The lab has to keep it for about 6 weeks. Another unique feature is that mycobacteria have mycolic acid in their cell envelope, which means that when you stain them, the stain is not removed by acidified alcohol. So these are commonly described as acid-fast bacilli, or AFB. Another characteristic of TB is that it has airborne transmission, meaning that we have to use negative pressure rooms and masks to protect ourselves and others from being exposed. So let's say that one of these bacteria escapes from the lungs of a person with active TB and then is inhaled by an uninfected person. If it gets down to the alveoli and establishes infection, that's called primary tuberculosis, which is usually marked by fever and possibly some pulmonary symptoms like cough. Most of the time, the chest x-ray is negative, but if it is abnormal, the most common findings are perihilar or right-sided infiltrates and ipsilateral hilar lymphadenopathy, so hilar lymphadenopathy on the same side as that primary infection. So that brings us to the Gone complex. When primary TB occurs, this may cause a lesion seen on chest x-ray called a Gone focus, where the primary infection occurred in the lung parenchyma. Now, when primary infection occurs, some of the TB will drain into the local lymphatic system, resulting in hilar lymphadenopathy that we see on chest x-ray. So when you have both the primary TB lesion, that Gone focus, plus the lymphadenopathy, we call that a Gone complex. So here you can see a Gone complex, which includes both the primary lung lesion, the Gone focus, plus the hilar lymphadenopathy. Now there are two possible outcomes of a primary TB infection. In about 90% of cases, the immune system fights the TB to a draw, basically, so that further bacterial replication is halted, and the infection kind of goes into a latent phase. So the bacteria are still there, just hanging out in the lymph nodes, and they're not really replicating. They're just kind of biding their time, waiting for more favorable conditions. Now, the other 10% of infected people cannot mount the appropriate immune response to control the TB, and they go on to have progressive infection. In this case, the TB may cause further local disease in the lung, or it can disseminate and cause miliary TB, where there are dozens of, maybe even hundreds of these tiny, tiny TB foci scattered throughout the lungs or scattered throughout other organs. Or it can disseminate to the CNS and cause meningitis. Disseminated TB can infect almost any tissue and cause a variety of complications like bone and joint disease, gastrointestinal TB, and so on. But then think back to the 90% of people that do control that primary infection. Many of them remain asymptomatic and latent for the rest of their lives, but not all of them. In some of these individuals, the TB can eventually become reactivated. Remember we said that the bacteria were merely biding their time. Well, if the immune system becomes weakened by cancer or HIV infection or simply old age, there's an increased risk of developing reactivation TB. Now, reactivation can present with fever, night sweats, weight loss. If it's reactivating in the lungs, you may see cough and hemoptysis. So most of the classic TB symptoms are really associated more with reactivation TB than they are with primary TB. On chest x-ray, you'll frequently see infiltrates in the apical posterior segments of the upper lobes. Remember that, it's important. On your exam, something going on in the apices of the lungs is going to be a good clue for reactivation TB. TB that reactivates outside the lungs can show up really almost anywhere, kind of like we saw with initial progressive dissemination. TB can disseminate hematogenously during primary infection, so it can show up in the CNS, the bones, the GI tract, the GU tract, the peritoneum, the cardiovascular system, you name it, TB can be there. So patients with risk factors for TB exposure that present with prolonged fever or weird, difficult to diagnose clinical syndromes, think about TB as a possibility. Now, how do we diagnose TB? Well, it depends on what phase of TB infection you're trying to diagnose and where you suspect the infection is. In a patient who has chronic cough and hemoptysis and weight loss, you're going to be thinking about active TB infection of the lungs, right? So in this case, we look at the sputum. One relatively easy way to get a preliminary diagnosis is to catch sputum from a coughing patient and then look for the bacteria under the microscope. So you're going to request 3 sputum samples from a patient at least 8 hours apart. And early morning sputum samples are more likely to have bacteria, so at least one of those samples needs to be an early morning sputum specimen. Then the lab's going to perform an acid-fast stain on the sputum and see if they can identify any bacteria. And there need to be about 10,000 acid-fast bacilli per ml of sputum for us to be able to see the acid-fast bacilli this way. So it's not a very sensitive test. That's why we need to get 3 sputum samples. But even doing so, we still get a lot of false negatives. So in addition to looking at the sputum microscopically, we're also going to send each of these sputum samples for culture on Lowenstein-Jensen agar, even if the AFB smear is positive. So this is going to help us ensure that there actually are TB that we're looking at, not some other non-tuberculous mycobacteria, and it allows us to test for antibiotic sensitivity. Then a third diagnostic test, again to overcome the low sensitivity of the AFB smears and the long length of incubation for your culture, the third diagnostic test is to perform PCR testing on the sputum samples when we have a high index of suspicion. But this method is not terribly sensitive, and it's also fairly expensive. Well, that's well and good for pulmonary TB, but what about TB reactivation elsewhere, like in the CNS or the GI tract or the peritoneum? Well, in those cases, you need to get fluid or tissue samples from the involved site for staining and culture. And unfortunately, that can be time-consuming and invasive and fairly painful. Now, what if you suspect latent TB? So this is where we use the tuberculin skin test. So we inject purified protein derivative, or PPD, into the skin to the inner aspect of the forearm and then wait to see if it becomes indurated at 48 to 72 hours. And if the skin does become indurated, that indicates prior TB exposure or possibly a current infection. Now, different patient risk groups are considered positive at different sizes of induration. And I don't think you're going to be expected to know this for step 1, but in the general population, they have to have 15 millimeters of induration at the site of the PPD to be considered positive. But over on the other end of the spectrum, in an HIV positive patient or somebody with immunosuppression for some other reason, or individuals with a known TB exposure, you're going to have a lower threshold for a positive test. So in those individuals, they're considered positive with just 5 millimeters of induration. And it's worth mentioning that one of the best known causes of a false positive PPD is vaccination with BCG, which is in the TB vaccine that's still given in some countries around the world. Now, another way to diagnose latent TB is called an interferon gamma release assay. 2 such tests are called quantiferon gold and T-spot. So these tests use a blood sample to see if the patient's T cells release interferon gamma in response to TB antigens. So one good thing about these interferon gamma release assays is that they're specific to TB and they don't cross-react with BCG. But the bad news about both the skin test and the interferon gamma release assays is that they can give false negatives, especially in people with suppressed immune systems like HIV patients, which unfortunately are often the people you want to screen, so it can be very frustrating. Once we've made the diagnosis of tuberculosis, how do we treat it? And we're only going to cover the standard treatment regimens here, although in practice it can become quite complicated. In a patient with latent TB, with no evidence of active disease right now, but who has risk factors for developing active disease, we treat with isoniazid alone for 9 months. Now, there are other possible regimens, but that's the preferred approach. But if the patient has active tuberculosis, the standard treatment includes 4 drugs for the first 2 months and then 2 drugs for the next 4 months. So you give 2 months of rifampin, isoniazid, pyrazinamide, and ethambutol, followed by 4 months of isoniazid and rifampin for a total 6-month course. And note that the first letters of these 4 initial drugs spell RIPE: rifampin, isoniazid, pyrazinamide, and ethambutol. Next, let's review the mechanisms of action, especially the side effects associated with each of these drugs, which can be significant. Let's start with rifampin. Rifampin is classified as a rifamycin, which includes rifampin, rifabutin, and rifapentine. Now, any of these drugs could be used in place of rifampin in treating TB for various reasons, which we're going to go over in a minute. But rifampin is by far the most common one of these that's used. Now, you can remember most of what you need to know about rifampin for step 1 by remembering the 4 R's of rifampin. The first R is the mechanism of action. Rifampin is an RNA polymerase inhibitor. Then the second R, rifampin revs up cytochrome P450. It induces P450 enzymes. Now, do you remember the mnemonic for all the P450 inducers? I'll give you a hint. Rifampin was the R in PBRs. Go back and review that if you need to. Now, because rifampin revs up P450, it can cause a lot of drug-drug interactions. Rifampin leads to lower plasma concentrations of things like warfarin, oral contraceptives, statins, levothyroxine, beta blockers, and especially some of the antiretroviral drugs used to treat HIV infection. So there are tons of important drug-drug interactions. Now, rifabutin does not rev up cytochrome P450 as much as rifampin does. So one use of rifabutin is treating TB in HIV patients who are taking antiretrovirals. Then the third R is for red. Rifampin causes body fluids like sweat and tears and urine and saliva to turn sort of a reddish-orange color. All the rifamycin can do this to a certain extent. It kind of freaks people out if you don't forewarn them. And it can also stain their clothes or stain their contact lenses. So one way you might be tested on this is a patient who has some indication for taking rifampin, and then they come in complaining of red tears or red urine, or they may say they have blood in their urine, but the dipstick is negative for blood and there are no red cells in the urine. And then the question is going to ask you what drug might cause this. Think about rifampin. Then the last R is for rapid resistance. We don't really use rifampin by itself most of the time because bacteria become resistant to it fairly rapidly if you use it alone. Then one other side effect to be aware of is hepatotoxicity, which is fairly rare. But unfortunately, hepatotoxicity is more common when you're taking rifampin along with other hepatotoxic drugs, such as isoniazid. So you do need to watch out for hepatotoxicity when you're treating somebody for TB. Now, besides TB, we sometimes use rifampin as prophylaxis in close contacts of patients with meningitis from Neisseria meningitidis or Haemophilus influenza type B. And it also has activity against MRSA, so that's another potential use. Now, we talked about using rifabutin instead of rifampin in HIV patients to avoid drug-drug interactions with antiretrovirals. And then rifapentine's claim to fame is that it has a longer half-life than rifampin does. So you can get away with once-a-week dosing, which is good for patients who aren't really reliable about taking their medications. And if you need to observe them taking each dose of medication with rifapentine, you only have to do that once a week. The next antimycobacterial drug in the RIPE regimen was isoniazid, or INH. Now, isoniazid inhibits the synthesis of mycolic acids, which are found in the mycobacterial cell envelope. Now, I mentioned that isoniazid causes some hepatotoxicity. It's common to see mildly elevated LFTs, and in severe cases it can cause full-blown hepatitis. Isoniazid is also associated with peripheral neuropathy, and we give pyridoxine supplements to patients taking isoniazid to prevent this. So really, we always talk about a 4-drug initial regimen for TB. It's really a 5-drug regimen because all these patients need pyridoxine, which is vitamin B6. So if you think back to farm basics, we mentioned that vitamin B6 is a cofactor for some of the enzymes involved in the synthesis of neurotransmitters like acetylcholine and norepinephrine. Well, isoniazid competes with B6 in those enzymes, so it inhibits neurotransmitter synthesis and causes some neuropathy. So we're going to give vitamin B6 supplements to overcome that. Now, another potential adverse effect of isoniazid is drug-induced lupus, although that's much lower yield for your exam. Definitely remember hepatotoxicity and peripheral neuropathy, and then the B6 supplement to prevent that peripheral neuropathy. Now, our next drug is pyrazinamide. Its mechanism of action isn't clearly understood, but it's used as part of this initial treatment regimen for active TB. Then the adverse effects that you need to remember include hepatotoxicity again and hyperuricemia. Now, the hyperuricemia is usually asymptomatic, although it can lead to some flares of gout. But the hepatotoxicity is important because you're loading up the body with not just one, not two, but now 3 hepatotoxins in combination. The last drug is ethambutol. Now, its mechanism of action is also poorly understood, but it appears to block an enzyme called arabinosyl transferase, which leads to decreased polymerization of the sugar arabinose into arabinogalactan, which is a major part of the mycobacterial cell wall. I don't really think that mechanism is particularly important for this test. But what you should know is that ethambutol causes optic neuropathy, which can present as red-green color blindness or decreased visual acuity. And fortunately, this is usually reversible by simply stopping the ethambutol. Let's move on from Mycobacterium tuberculosis to some other species of Mycobacterium that you might see on your exam. First up, there's Mycobacterium avium intracellulare, or MAI. You may also see this referred to as Mycobacterium avium complex, or MAC. This can cause a pulmonary syndrome that's similar to TB, and then in immunosuppressed patients, like patients with AIDS, MAC can disseminate. Now, symptoms in these cases depend on where the mycobacterium has spread. For instance, if MAC goes to the GI tract, the patient might have abdominal pain and diarrhea. If it's in the bone marrow, the patient may have anemia and neutropenia. But MAI is such a problem in HIV patients that we give antibiotic prophylaxis. And there are 2 points you need to know about MAI prophylaxis. The drug we give is azithromycin, given once weekly. And we begin prophylaxis when the CD4 count falls below 50. Now, not every patient with HIV infection has AIDS, but when the CD4 count is below 200, that's definitely considered AIDS. So in an AIDS patient with a CD4 count below 50, you give azithromycin once weekly to prevent MAI. Another mycobacterial species to know is Mycobacterium kansasii. So this causes a pulmonary syndrome almost exactly like TB. The symptoms and X-ray findings are very similar to what we see in TB. A third non-tuberculous mycobacteria to know is Mycobacterium marinum. So this species is a little bit different. It causes cutaneous disease. And as the name implies, you get this one from exposure to contaminated water. So Mycobacterium marinum can live in both fresh water or in salt water, and includes swimming pools and fish tanks. And then it enters the skin through wounds or small breaks in the skin. It's frequently called fish tank granuloma because so many people get this infection from fish tanks. Our last mycobacterium is Mycobacterium leprae, which causes Hansen's disease, or the old-fashioned name is leprosy. So this mycobacterium likes to infect the peripheral nerves and the skin. Now, leprosy exists as a spectrum of disease, with lepromatous disease on one end and tuberculoid disease on the other end. So lepromatous disease occurs when there's a weak immune system to the mycobacteria, and the skin lesions have a lot of mycobacteria organisms in them. So these patients often have diffuse and disfiguring disease like you see here. Tuberculoid disease occurs when there's a strong immune response to the infection, and the lesions have very few mycobacteria present. So these people have relatively few skin lesions, which tend to be a little hypopigmented or erythematous instead of being so disfiguring. And they also have loss of sensation in the affected skin. These patients are sometimes difficult to identify because the findings are very subtle. And as I said, this is a spectrum of disease with a lot of gray area in between. It isn't always perfectly clear cut. Now, in addition to the skin lesions, Mycobacterium leprae infects peripheral nerves, and this can result in enlarged peripheral nerves and peripheral neuropathy, especially early on. This neuropathy leads to loss of function and repeated trauma to these areas. Now, in the southern U.S., leprosy can be a zoonotic infection. It's transmitted by the 9-banded armadillo. In the less armadillo-inhabited parts of the world, it's spread person to person, possibly through respiratory secretions. So individuals with lepromatous disease are most likely to transmit it to somebody else, considering the lack of immune response and the heavy burden of mycobacteria that they carry in their body. Now, Mycobacterium leprae cannot be grown in culture, but it can be identified by PCR, so that's how you're going to make the diagnosis. And we treat leprosy with a multi-drug regimen like we use for most mycobacterial infections. For patients with tuberculoid disease, we give dapsone and rifampin for 12 months. For patients with lepromatous disease, we give dapsone plus rifampin plus clofazimine for a total of 24 months. And let me remind you a couple of quick things about dapsone. So we use it to treat Hansen disease. Now, where else do we use dapsone? Well, it's one of the second-line options for prophylaxis or treatment of pneumocystis jirovecii. And do you remember hearing about an interesting adverse effect of dapsone? Well, dapsone is one of the drugs that causes hemolysis in patients with G6PD deficiency. There's one other drug we've mentioned in this video that also causes hemolysis in these patients. Do you remember what that was? It's isoniazid. So both dapsone and isoniazid are drugs used to treat mycobacterial infections that cause hemolysis in patients with G6PD deficiency. And that's it for Hansen disease. And on that note, let's bop on over to the study guide and work through the end of session quiz. First question, what's the distinction between a GON complex and a GON focus? And are these seen in primary TB or reactivation TB? So a GON focus is a lung lesion from primary TB infection, and then a GON complex is where you have a primary TB lung lesion plus hilar lymphadenopathy. So you can have a GON focus by itself, but if you have a GON focus plus lymphadenopathy, that's called a GON complex. And again, both of these are seen with primary tuberculosis. Next, what does a positive PPD skin test indicate? Well, it usually indicates true TB infection, either active or latent, but it can also indicate a history of BCG vaccination or infection with a non-tuberculous mycobacterium. So leprosy or MAI will also give you a positive PPD. Then the next question says, what does a negative PPD indicate? Well, these could be either true negatives or false negatives. So true negatives would be all the people that did not have TB at all. But you could also see false negatives in patients who did have TB but were on immunosuppressive medications like steroids, or perhaps patients who are immunocompromised from HIV or AIDS or cancer or advanced age. Or there could be technical difficulties with placing the PPD. Maybe they didn't inject enough or they stored it at the wrong temperature, something like that. The last question. A patient's attempting to recall for you what medications he's taking, and there's one medication he's taking to keep his lungs healthy that he also says can hurt his nerves unless he takes his B vitamin. So to what medication is he referring? The most likely medication would be isoniazid, which he'd be taking to treat latent TB. And because isoniazid can cause neurotoxicity, he should continue to take his B6, which is pyridoxine. Now let's look at these rapid fire facts. So associated with a GON focus or GON complex, again that's primary TB. Associated with lung infiltrate in the apical posterior segments of the upper lobes, that's reactivation TB. Then the standard initial treatment regimen for TB is RIPE, rifampin, isoniazid, pyrazinamide, and ethambutol. That's it for now. I'll see you next time.